complété son cours de médecine, sa résidence à l'Université McGill, puis a fait un fellow dans le programme des troubles de l'humeur à l'Université d'Ottawa, à l'hôpital Royal là, avec Dr Amblier. Là, il y a certains autres personnes ici là, qui ont fait leur fellow aussi là-bas. Euh, voilà, avec Dr Zigman a un rôle de leadership là, au MUHC. Puis, à l'extérieur de l'hôpital, il aime aussi la musique. Il joue du piano et de la guitare, fait du vélo. On va nous parler aujourd'hui d'un sujet qui est intéressant et controversé sur l'usage des benzodiazépines. La présentation va être faite en anglais, mais Dr Zigman peut prendre les questions en français au besoin. Alors, merci d'être là, Dr Zigman, on vous écoute.
Hi, everyone. So I got into this topic because I was coordinating a psychopharmacology module for the residents, and I was presenting one of the lectures on benzodiazepines, and a lot of the ideas that I had about benzodiazepines that had been taught to me when I was training. I looked in the literature as I was preparing the original talk for the residents, and I was like, I'm not so sure that this is really supported by what the data says. So I decided to take this as a deep dive to look more globally about benzodiazepines, what's their role in psychiatry, what does the data actually show about their risks and benefits. And I actually learned a lot from just preparing this talk. So I have no conflicts of interest. I will be discussing off-label uses of medications. The main objectives are to understand the pharmacology of commonly used benzodiazepines, understand the risks and benefits, and understand controversies in the medical literature about benzodiazepines. So we'll start with a little bit of history and some pharmacology, and then we'll focus mainly on the risks and benefits and deprescribing. So this is the Rolling Stones song, Mother's Little Helper. It's talking about Valium in the 1960s. What a drag it is getting old. Kids are different these days. I hear every mother say mother needs something today to calm her down. And though she's not really ill, there's a little yellow pill. She goes running for shelter of her mother's little helper, and it helps her get her way, get her through her busy day. And more recently, Billie Eilish had a song called Zanny, which I was playing a bit earlier for those of you who joined early. One designated drives home, the only one who's not stoned. Don't give me a Zanny now or ever. What is it about them? I must be missing something. They just keep doing nothing, too intoxicated to be scared. So there's, dating back all the way from the 60s, there's this idea in pop culture about numbing yourself with these medications. And also a use of these medications for people who are not actually seriously ill, who are using them. In the Rolling Stones song, it says, although she's not really ill, there's a little blue pill that's helping her get through the day. And in the Billie Eilish song, people actually misusing benzos at a party. So there's the idea in pop culture that these are drugs that are taken not by people with serious illnesses, but rather to get high or to kind of numb yourself. So sedatives, the first sedative was chloral hydrate in the mid-19th century. And then phenobarbital and the barbiturates were developed in the early 1900s and used as anxiolytics. However, the biggest development was meprobamate, which is called Milltown. And in the mid-50s, it becomes the first blockbuster drug. And a third of all prescriptions in the United States were for this drug in 1957. In the 1960s, Librium or chlorodiazepoxide or Valium diazepam are developed, and they largely replace the barbiturates due to a better safety profile. lower risk of death from overdose. And then benzodiazepines start falling out of favor in the 1980s as the SSRIs are developed, which are thought to be safer alternatives and considered to be the first-line medications for anxiety disorders. Also around this time, class action lawsuits start coming out about the risk of dependence and car accidents with the benzodiazepines. So let's talk a little bit about the pharmacology. So the benzodiazepines are working on the GABA system. The GABA system are the main inhibitory neurons in the CNS. They are linked to voltage-sensitive chloride channels and lead to depolarization of neurons. The GABA receptor is a 5-subunit receptor, and different types of GABA receptor have a different alpha subunit, which leads to different pharmacological effects. So here's a beautiful picture from the New England Journal of Medicine of this 5-subunit receptor. The GABA is the endogenous ligand. It binds to one site on the GABA receptor, which opens the receptor for chloride ions. And then the benzodiazepines bind to a different site than GABA's. And they facilitate opening in the presence of the endogenous ligand. So they're not actually agonists, as it says here. They're called positive allosteric modulators. So on their own, whereas I think the barbiturates were actually agonists. They would open the channels, and that led to increased toxicity. As I said earlier, there's different subtypes of the GABA A receptor determined by different alpha units. The alpha 1 unit is linked more closely to sedation, and the Z drugs like zopiclone are selective for the alpha 1 unit, whereas the benzodiazepines are non-selective. Theoretically, it could be possible to develop alpha 2 or alpha 3 selective, which would have anxiolytic effects, but without as much addiction potential, without as much sedation. They've tried doing this in animals. They've tried human trials of some of these promising drugs, but they didn't really seem to work properly. I don't have a good explanation of why that is. I never saw convincing. It's possible that the doses that are needed in adults lead to loss of the selectivity. Also, it's very hard to develop selective drugs because of the conservation of the binding site, the amino acid shape. When you do activate the benzodiazepine receptor and you increase GABA neuron firing, you disinhibit dopamine release. So that will increase dopamine release in the nucleus accumbens, and that will be responsible for the addictive potential. So looking at some of the more commonly used benzodiazepines, one important thing to think about is their lipid solubility, and that will determine how rapidly they start working. The commonly used benzodiazepine with very high lipid solubility is diazepam, and that has the most rapid onset of action when given orally. The one with the slowest onset of action is oxazepam. And theoretically, the more rapid the onset of action, the higher the addictive potential, the slower the onset of action, the less of a buzz you get from it. So oxazepam could potentially have a lower addictive potential than diazepam. The other thing that's relevant is the metabolism. So there are 3 that are metabolized by glucuronide conjugation. So people with liver impairment or taking other medications could have changes in their cytochrome P450 system, and the lorazepam, oxazepam, and temazepam. So they are metabolized by the liver, but not through the CYP system, would be less likely to have drug interactions and be preferable in people with hepatic impairment. So let's start by going over the benefits and their clinical use. So benzodiazepines are So benzodiazepines, the first line uses are not controversial at all. I think everyone would agree that they're useful in acute seizure, for rapid tranquilization of agitated patients, for procedural sedation, for alcohol withdrawal and delirium tremens, for managing an acute panic attack, and for catatonia, where you actually need very high doses of benzodiazepines sometimes. Now, the controversy comes more for their second line use and other uses, treating resistant generalized anxiety, social anxiety, and panic disorder. That said, most guidelines do place benzodiazepines as second line drugs for generalized anxiety, social anxiety, and panic. So here we have the Canadian guidelines from 2014. And you see benzodiazepines as second-line drugs for generalized anxiety. This is the Harvard psychopharmacology algorithm, where benzodiazepines are, again, second-line drugs, either for augmentation or for people who don't improve with an SSRI. Studies, there are some meta-analyses that looked at the difference in response between benzodiazepines and SSRIs, although I found only one study that actually directly compared them in a randomized trial. And it was from over 30 years ago. Essentially, benzodiazepines have a greater effect size than the SSRIs and SNRIs. The benzodiazepines are more effective for the somatic symptoms and similarly effective for the psychic symptoms of anxiety. In panic disorder, again, they're second-line drugs for people who do not respond to the SSRIs. I found only one study that directly compared them. It was from 2011. So it was an open-label randomized trial. It compared clonazepam to paroxetine. And there were small differences favoring clonazepam for efficacy, with less panic attacks from baseline, especially earlier in treatment. Clonazepam had less side effects than paroxetine, including, if you look here, less cognitive side effects than paroxetine. Now, paroxetine may not be the best SSRI to use as a comparator, but this was quite interesting to me. Similar drowsiness to paroxetine, even like less patients reporting drowsiness compared to paroxetine. At 1 year and 6-year follow-up, patients initially treated with clonazepam had lower relapse rates compared to paroxetine. For social anxiety, again, they're listed as second-line drugs. Again, in the Harvard guidelines, they're considered to be a second-line medication for people who have not responded to a first SSRI trial. And one randomized trial looked at sertraline plus, for people who did not respond to sertraline plus placebo versus switching to venlafaxine versus sertraline plus clonazepam. And adding clonazepam to the sertraline was more effective than sertraline alone. And there was some numerical superiority over switching to venlafaxine, though the study might have been underpowered to detect a difference. As sleep aids, they increase sleep duration by about an hour. They enhance the perceived sleep quality. They decrease sleep latency, so they make it faster to fall asleep. They slightly reduce REM sleep, and they do reduce slow wave sleep. So slow wave sleep is the restorative sleep, so they have an effect of reducing the restorative sleep. Importantly, for sleep, tolerance develops after about 1 to 2 months. So it does not make sense to use benzos long-term as sleep aids because tolerance develops relatively rapidly. Okay. So on the contrary, though, is that if the insomnia is caused by anxiety, it may continue to respond to the benzodiazepines longer term and not stop after 1 to 2 months. So the recommendation was that benzodiazepines or Z drugs may be appropriate for acute situational anxiety, but CBTI is the treatment for chronic anxiety. For patients with major depression, a Cochrane review showed that the combination of a benzodiazepine plus an antidepressant was more effective than an antidepressant alone for the first 4 weeks, with less dropouts due to adverse events and then in the combination group. But the benefits were not maintained over 4 weeks. So the recommendation would be that if a patient with anxious depression is treated with the benzodiazepine, it's better to continue to keep that to the first 4 weeks of treatment. Now, another important question that often comes up is, should I be prescribing a benzodiazepine as scheduled dosing? So take this multiple times per day at regular intervals, or PRN triggered by anxious distress. So some people have written about this, and the take home would be that only scheduled dosing has been studied for management of chronic anxiety disorders. Scheduled dosing is the only type of prescribing that has been studied in randomized controlled trials. Scheduled dosing leads to less inter-episode rebound anxiety. PRN dosing has been understudied, but PRN dosing leads to less benzodiazepines taken, less sedation, less cognitive effects, and a lower risk of dependence. Practically, many benzodiazepine users will vote with their feet. So they'll start with scheduled dosing and then shift to PRN use, or a combination of using PRN and scheduled dosing on their own. The PRN dosing might be useful for situational triggered anxiety that doesn't occur every day, like somebody who gets anxious before they need to give a public speech. And if the person's able to get away with about 10 to 20 doses a month, then it may be better to give them PRN dosing because they would be taking less benzodiazepines each month. So those are the benefits. What can go wrong? So benzodiazepines cause decreased alertness, impairments of psychomotor performance, and memory dysfunction. The negative effects of benzodiazepines on cognition are partially due to the sedation, and they may improve as the patient becomes more tolerant to it. The flip side of that is that patients with a lot of anxiety can develop cognitive impairment, indecisiveness, concentration problems due to their anxiety, and treating them with a benzodiazepine may improve their cognition, similar to what we might see with ECT in somebody who's severely depressed. That although ECT causes cognitive problems, the depression also causes cognitive problems, and treating the depression will lead to an improvement in cognitive performance for some people. Benzodiazepines and Z drugs are linked to road accidents, about 2 times risk. Higher doses confer a higher risk, but importantly, SSRIs and TCAs are also linked to an increase in road accidents, with a similar risk. So the best number to be looking at is the single crashes in which the fault is clear, because a road accident could be due to the other person. So if we're looking at and then they're trying to adjust for other potential confounders. So we're seeing that the benzodiazepines this 2.49 versus 2.25, it's pretty similar to the risk that you have with antidepressants. I was expecting also, as an aside, to see an improvement with the ADHD medications, but you see an increase in risk with the ADHD medications as well. One thing that we're taught is that benzodiazepines cause falls in the elderly. Yes, they do. They double the risk of a fall in elderly people. However, antidepressants and antipsychotics are associated with a similar risk of fall in elderly people, and SSRIs actually may be associated with a higher risk of falls than benzodiazepines, especially at the beginning of treatment. You may have heard of paradoxical effects. So this is the idea that somebody taking a benzodiazepine can become agitated and disinhibited. I like to give the analogy of the drunk person fighting with the bouncer outside of a bar and at 3 o'clock in the morning. So benzodiazepines have an effect in the brain somewhat similar to alcohol. This is probably similar to the disinhibition that we would see with alcohol. It's more likely to occur in elderly people, people with pre-existing cognitive impairment, and patients with cluster B personality disorders like antisocial or borderline. Even taking high-risk populations in a psychiatric, patients admitted in a psychiatric ward, they looked at 323 patients, psychiatric inpatients treated with alprazolam or clonazepam, compared to no benzodiazepine, and there was no difference between the groups in any of the outcomes that they looked at, including self-injury, assault, need for seclusion and restraint, need for observation, or changes in their privileges. So in this high-risk population, there did not seem to be an increased risk of acting out behavior triggered by benzodiazepines. One thing that I had always been taught is that if you give benzodiazepines to somebody who's receiving ECT, sorry, not ECT, CBT, thérapie cognitive comportementale, that it would decrease the chance that they would improve with the CBT. This comes from idea that benzodiazepines can impair extinction learning in animal models, and that it can reduce the fear that you would need in order to get an anxiety response from the exposure. However, the data does not support this concern. 9 out of 12 studies showed no effect of benzos on post-treatment outcomes, actually improved in 2 of the 12 studies. And 6 out of 11 showed no effect in follow-up. There were some that showed an increased anxiety when the benzodiazepine was withdrawn, though it's difficult to say that whether that was from withdrawing the benzodiazepines versus an impact on the learning. So some people might say, some people have argued that maybe when you learn something when you're in a certain state, like taking the benzodiazepines, and you withdraw the benzodiazepines that change the state that the person's in, that the learning may not be maintained in a different state. So that's one theory, but it's also possible that the increase in anxiety and the reduced that you're seeing when these drugs are withdrawn is specifically due to withdrawing. Another thing I was taught was that if you give benzodiazepines to somebody who has just had a trauma, it could increase their risk of developing PTSD. And there's a concern that benzodiazepines can interfere with memory consolidation, which is important for the development of PTSD. So there have been some studies looking at hospitalized patients, mostly in the ICU with military trauma, which showed an increased risk of developing PTSD if they were receiving benzodiazepines. But these were heterogeneous and poor quality studies. Only 2 small trials, only one of which was an RCT, actually studied this specifically with the goal of the trial. And They did show a numerically higher rate of PTSD, but there was no statistical significance between the two groups. The conclusion of the authors who did this systematic review was that there was no conclusive evidence that the use of benzodiazepines in the aftermath of a post-traumatic event can increase the incidence of PTSD or contribute to its severity. Okay. The other thing that we often worry about is benzodiazepine dependence. So this is different from sedative use disorder. So it's a predictable neuroadaptation that occurs when people use benzodiazepines regularly, and it will occur in about 50% of people who use benzodiazepines for over a month. So what is often seen is physical and psychological dependence, even at low doses. So in the absence of tolerance, people continuing to take 1 milligram of lorazepam and still feeling that they need that 1 milligram of lorazepam. And when it's discontinued, they may have withdrawal effects, physical symptoms, psychological, and rarely, particularly people taking high doses, could have delirium or seizures. So while tolerance and physiological dependence is common, tolerance to the therapeutic effects is uncommon. So two large population-based studies showed that less than 10% of long-term benzodiazepine users escalated their doses above the recommended therapeutic doses over time, and that comorbid substance use and depression were the main risk factors for increasing doses. So when we think about sedative, hypnotic, or anxiolytic use disorder, SHAUD, SHAUD, it's the general criteria for a substance use disorder. It's no different than the criteria for alcohol or cocaine, except if you look at items 10 and 11, tolerance and withdrawal, you'll see that there's a specification here that you're not supposed to count these items if the drug is being used under medical supervision. So it's expected that the patient will develop tolerance and have withdrawal symptoms as part of the treatment with benzodiazepines, the way that you would also develop withdrawal symptoms as part of the treatment with SSRIs. So sedative, hypnotic, anxiolytic use disorder, about 0.3% 12-month prevalence, often starts in late teens to early 20s. It's rarely seen as the only substance use disorder. It's often people combining benzodiazepines with other drugs like stimulants, opiates. It's comorbid with other substance use disorders, antisocial personality, panic disorder. One study looked at doctor shopping as a proxy for trying to figure out which drugs are more likely to be misused. And they found that of the drugs that we have in Canada, this drug we don't have, flunitrazepam. Diazepam was more likely to be misused than alprazolam, bromazepam and clonazepam, and the others had a lower abuse potential. So if we compare the adverse effects between benzodiazepines and the drugs that they're usually used instead of, which would be the SSRIs, we're seeing that falls, yes, with benzodiazepines, but also with SSRIs. Car accidents, both of them. Withdrawal, both of them. Abuse risk, that's the benzos only. Sexual side effects with SSRIs, but less so with the benzos. Weight gain with SSRIs. Cognitive side effects we may see with both of them. Sedation may see with both of them, and bleeding with SSRIs. Okay, so now we'll move on to deprescribing. So if you have a patient with one of these conditions who is taking benzodiazepines, they may consider trying to discontinue the benzodiazepines. Ideally, you're trying some of these other therapies first, such as an SSRI or CBT. Some alternatives to benzodiazepines for people taking them as sleep aids. There's the DORAs like lemborexant, sedating antihistamines like doxepin or hydroxyzine, trazodone, and mirtazapine. For panic disorder, there are a couple of studies adjunctively using beta blockers, particularly pindolol and propranolol. For generalized anxiety disorder and social anxiety, there's pregabalin, or lavender oil and hydroxyzine for generalized anxiety disorder. For PTSD, some studies with quetiapine, prazosin, and trazodone for sleep, and clonidine. I've started using a little bit more for my PTSD patients, particularly for the physical symptoms with some benefit. So these are the Canadian deprescribing guidelines. They say that if you're thinking about deprescribing a benzodiazepine, the first question is, why are they taking a benzodiazepine or a Z drug? If it's for insomnia, then recommend deprescribing. If it's for other sleep disorders, anxiety, or alcohol withdrawal, then consider continuing the benzodiazepine receptor agonist. So we'll go over how to manage benzodiazepine dependence. These are the standard recommendations, which are really developed more for people who are abusing benzodiazepines rather than taking them long-term for anxiety. So the recommendation is to discontinue them over a 4 to 8 week period. May consider longer for people with higher doses, taking more than 30 milligrams a day of, they say 3 to 8 weeks for people taking diazepam doses of 30 or higher. So that would be equivalent to about 3 milligrams of lorazepam per day. So they suggest that you can first reduce the dose by about 50%, and then you can continue reducing by 10 to 25% every 2 weeks. This is not the hyperbolic taper. This is just reducing from the original amount. They are suggesting avoiding prolonged tapers, because then people start becoming more preoccupied about the benzodiazepine for a very long time. If the patient's taking multiple benzodiazepines, convert it to just one. They prefer diazepam. But switching to diazepam is not associated with a better outcome. It's better just to continue whatever they're taking and taper that one. They suggest making it every Monday that you start reducing the dose, and that the patient know that they're reducing each week, typically on Monday. Try other sleep aids if necessary, and there is no pharmacotherapy that is reliably effective. They've looked at pregabalin, carbamazepine. There's nothing that really is very useful. So there are a couple of alternative taper strategies. One group tried studying a blinded taper. So they gave everybody CBT for insomnia, and group one had a standard gradual taper, and the other group had a masked taper. So the patients did not know the doses that they were taking, and they did not know when they would be changing doses. But the patients had a dose reduction of about 25% every week over 9 weeks. And they had some better outcomes as far as actually getting patients off of the benzodiazepines with the masked taper. There is this other strategy, which I alluded to earlier, called the hyperbolic taper. It was put forth by Heather Ashton, and you can find it in the Ashton manual. So they are advocating to switch everybody to diazepam and do a very slow taper for up to 18 months for people who have difficulty discontinuing benzodiazepines. They talk about using compounding pharmacies and making liquid preparations in order to make these very, very tiny dosing. And this is not something that I would usually do, but if you have somebody who's having a lot of difficulty getting off of benzodiazepines, it could be worth considering. So a word of caution about withdrawing patients from benzodiazepines. There was a recent study that looked at a large claims database of people who were taking benzos for most days for over a year. And they compared people who discontinued benzodiazepines versus those who continued them. And the discontinuers had a higher risk of death compared to the ones who stayed on their benzodiazepines. It didn't make a difference whether they were taking opiates together or not. And a theory is that that this may be related to people choosing other substances than the prescribed benzodiazepines as alternatives. This is something that was also seen when they tried to stop people's opiates. Now, you will, if you search on the internet, you will find people giving stories about something that they call protracted withdrawal. And this is very controversial. There was a survey from online websites about that were focusing on patients, people who had difficulty withdrawing from benzodiazepines. And many of them endorsed various vague symptoms, including sleep disturbance, sensitivity to light, muscle weakness, GI symptoms that were lasting months to years. There was many endorsed suicidal thoughts. Some thought that the benzodiazepines had basically ruined their life. And the authors coined this term called benzodiazepine-induced neurological dysfunction. You can see some examples of some of the symptoms that they were endorsing. Some of these lasting years: sleep disturbances, memory loss, muscle weakness, gastrointestinal symptom, trouble walking, spasms. Now, the reason why I look at this with a little bit of healthy skepticism is that about a third also reported new food allergies and sensitivity to chemicals like MSG and soy. I can see no I could see no physiologic reason why that would occur. I've also asked colleagues who have through like psychiatry internet groups, whether they actually see this in practice, patients with protracted withdrawal. And they said only the ones who are looking at these internet groups. So that there is a possibility that one thing that could be going on is nocebo effects or some form of mass psychogenic illness. Where you read about symptoms and then you're more likely to have them, similar to what people might experience with chronic Lyme, what neurologists will see with chronic Lyme disease. When we look at animal models of non-human primates, their withdrawal symptoms tend to last days to weeks, not months to years. Though, to be fair, in these studies, the non-human primates are not treated with benzodiazepines for as long as many of these people have been treated. So I thought I would end with a perspective of one of my patients who he's a 60-year-old man who had a history of bipolar disorder type 1, panic disorder, alcohol use disorder, cocaine use disorder, and had a history of misusing sedatives. Previously took lorazepam up to 12 milligrams a day. At the time that this happened, he was taking lamotrigine, quetiapine, naltrexone, pregabalin, was attending an addictions program. And he was telling me that he was having daily panic attacks. They were lasting hours. He was lying in bed all day. It was difficult for him to even go to the bathroom because of his severe claustrophobia. His mother had a prescription for lorazepam, and he was taking 1 milligram twice a day. felt that this was helping his panic. He ran out of the clonazepam and instead resorted to cocaine, which led to an emergency visit and suicidal ideation, having to stay at a crisis center. So his wife was pressuring me to have him restart the lorazepam. She said it was helping a lot. He was more functional. And she says she's going to supervise his medication. And he actually had a significant improvement when it was started. He wasn't lying in bed all day. And I asked him to write about his experience. And he says, I write this as a patient who has formerly abused both alcohol and benzodiazepines. Now that I'm taking benzodiazepines as prescribed, I no longer wake up in the morning unable to use the restroom due to my state of panic and claustrophobia. I no longer spend the first 2 hours in the morning in a rocking motion just to avoid the anguish and severity of anxiety. I've heard it over and over again that benzos are like alcohol in pill format. As somebody who's previously abused alcohol, nothing is further from the truth. Alcohol consumed and atrophied my body and denigrated my spirit. Benzodiazepines don't. And he finishes, how many people do you see wasting away on the sidewalks because of benzodiazepines? So I thought that this article was very interesting. It talks about the paradox of long-term benzodiazepine treatment. And they start, the published literature presents two starkly different pictures of long-term benzodiazepine treatment. The negative view is comes from withdrawal programs like the Ashton program, showing that a third of patients have difficulty discontinuing their benzodiazepines. They describe severe physical and psychological symptoms during both the use and the taper. That some patients report a major functional decline that they attribute to the benzodiazepines, and professional guidelines support limiting them to short-term use. Whereas the positive view is that studies showing some patients taking them for up to 3 years with stable dosing, sustained benefit, and no loss of effect. The long-term users don't display these severe adverse reactions that are described about, like the global functional decline, the muscle spasms, and the withdrawal phenomena are similar to antidepressants with better anxiety management. So they suggest that this paradox might have to do with different populations that are being treated. So in the treatment study, you're dealing with people with well-defined anxiety disorders who are in psychiatric care, who are getting protocol-based scheduled benzodiazepines. Whereas in the withdrawal studies, you have people who are being treated usually in primary care with vague or no clear diagnosis. The benzos were started for unclear reasons like insomnia, situational anxiety, or somatic symptoms, and the data on their treatment history and motivation is lacking. So they suggest that benzodiazepines might be appropriate for acute and long-term maintenance for panic, social anxiety, generalized anxiety, and when people have features of mixed anxiety disorders. They should be continued only when there's a clear and sustained benefit at stable doses. Educate the patient about the targets, limitations, and goals, and the need for psychotherapy adjunctively or together with the benzodiazepines. Aim to reduce the anxiety so the patient can use CBT to improve their coping skills. And if benzo is for anxiety or insomnia due to life stressors, it should be closely monitored. You should be trying to avoid using it for more than a few weeks. And if you do need to reassess the patient repeatedly, and taper the benzos for reasons that are specific to the individual patient and agreed upon by the patient. Taper should be flexible, collaborative, and supportive. So one of the things that I have started telling my patients, benzos will only help you if you take them and try to live your life. I'm only going to be continuing them if the benzos are helping you live a normal life rather than taking them and lying in your bed and retreating from the world. So that's it. So in summary, benzos are reasonable second-line treatments for difficult to treat anxiety disorders. Yeah. They come with risks, but generally comparable to other available treatments. If they're used, weigh the ongoing risk versus benefit and consider deprescribing when patients are on board. And you may consider the blinded or slow hyperbolic taper if preferred by patients. So that's the end. I have some MCQs, but I think we can spend some time with questions.
All right, thank you so much for the presentation. Very instructive. And so yeah, we can go ahead with questions. So I don't see the name. I see Tess. I guess Dr. TC.
Yeah, hi. Thanks for the great talk. I was under the impression, contrary to the data shown at the table, the beginning of the presentation, that alprazolam is substantially more lipophilic, hence crossing the blood-brain barrier more rapidly and higher propensity to create euphoria, rapid dependence. That could be the reason why it's the preferred benzo party drug alluded to in the Billie Eilish song, and that specifically that one we should not prescribe. On top of that, there's I think the Mexican cartel caught up to it, and they're distributing Xanax tinted with fentanyl. So that could be a reason, a few reasons why not prescribe that benzo specifically. What are your thoughts on that?
So I think that it has a high, compared to diazepam, it has less lipophilicity. It is one of the ones that on the street people tend to misuse. Why that is, if we look again at the doctor shopping, that it was less preferred compared to diazepam. So that's all I have from the data, but I have heard the same thing. It's not it seems like diazepam is better at least than the alprazolam as far, or has a higher addiction potential than the alprazolam.
Right, thanks. Last comment is with regards to the hyperbolic tapering from Dr. Ashton.
Yeah.
She uses Valium because of the long half-life, also the small increments. But with elderly people, I tend that she goes very high doses. We have to be careful. She has tables in there. And sometimes with elderly people, my experience is that maybe it's a bit too much. That's all I have to say.
Very
Thanks a
true.
lot again for the thought. Yeah.
My pleasure.
Like lots of the negative on benzos seem to come from the more like addiction medicine literature, and like from a general psychiatry perspective, like the negatives weren't that impressive. Like so, like I don't know. What are your thoughts on that? Like it seems like maybe they're a little bit less evil than what we're made to think.
Yeah, so I have the same impression. So I'll say that as a medical student, I did an addiction psychiatry elective before I did my general psychiatry, like back when I was a med two and we were able to do electives. And I came in with this like horrible idea of benzodiazepines being like the worst things that you could possibly give people, especially people with a propensity to misuse substances. And the contrary is I see people on a regular basis who I'm treating for anxiety disorders, and they tend to be quite hesitant to actually take benzodiazepines, right? One of my other colleagues said, if you have a patient who really wants benzodiazepines, be cautious giving them benzodiazepines. If you have a patient who's hesitant to take benzodiazepines, they're probably fine to give them benzodiazepines.
And any thoughts on, I find like bipolar patients often have like persistent, like kind of intense anxiety. I find they're a good subgroup of patients. Sometimes, like I don't really mind giving them more ongoing benzos for that sort of bipolar disorder related anxiety. Like anything, I've had.
Yeah, so first of all, benzodiazepines are an effective adjunctive management for mania. That they have anti-manic effects, probably by improving sleep quality. So if you do have a manic patient in the emergency department or on the inpatient ward, I would have a very low threshold for giving them benzodiazepines. As far as treating an outpatient with bipolar disorder who has anxiety, I would usually try quetiapine because it can help with both the bipolar disorder and the anxiety. I would often try pregabalin, but I do wind up offering a lot of them benzodiazepines. The main situation where it doesn't work is really OCD, and then you're kind of stuck with the SSRIs, using them very cautiously, and especially in bipolar 1 patients with a good anti-manic agent on board.
Okay, well, thank you so much for taking the time to share this presentation with us. Merci beaucoup, Dr. Zigman, d'avoir pris le temps.
Merci à tous.